managing patients who've had a reconstruction of some sort, whether that's because they've had a cystectomy before, or maybe they've had a ureteric reimplantation, or maybe they've had a transplant and then a ureteric reimplantation from that, is very challenging. And the reason that it's challenging is because access from below to be able to access the kidney retrogradely can be difficult. So it's a bit of a balance between a more difficult access retrogradely versus a puncture to the kidney and an antegrade access, which might have more complications for the patient. So this first case is a 60-year-old man who's actually got bilateral ureteric stones. This patient has previously had a cystoprostatectomy and urethrectomy and had an ileal conduit for bladder cancer about 3 years previously. And he's had bilateral nephrostomy tubes inserted about a month ago. He's also had bilateral antegrade stents inserted, but unfortunately these migrated out of the conduit within 10 days or so. He was referred to me by a colleague who had already tried retrograde access, but that retrograde access hadn't worked, and so I was asked to evaluate the case and to plan management. We can have a look through the CT scan now, and we're going from superior to inferior, and you can see that we've got a small stone in the lower pole of that left kidney. And then as we go down, you can see that we've got some dilatation of the ureter on the right side and some dilatation of the ureter on the left side as well. And we can follow this dilatation down until where the ureters join. And you can see we've got some stone at the join of the conduit. Retrograde access hasn't been successful. So the plan in this case was to try bilateral simultaneous antegrade access. And what we would normally do is we gain access to the kidney using a wire. This patient's already got nephrostomy tubes in, so we can easily gain wire access to the kidney. And then we would dilate with a fascial dilator, use a 10 French fascial dilator. And then we'd normally use actually a short 11-13 access sheath, which we would then pass into the kidney, and that will give us access into the renal pelvis and upper ureter. You can see here now we've got the patient is actually turned prone, and we're trying to pass a wire out into the conduit. You can see that we've got our access sheath all the way down to that lower ureter, and then we've got a flexible ureteroscope which is down there, having a look and trying to see if we can access the stones which we saw. We have actually got flow of contrast through into the conduit, but unfortunately there's a very narrow stenose segment, which means that from the left-hand side, we're actually unable to access the stones which are at the plate where the ureters join in a Wallace-type fashion, the ileal conduit. This is the endoscopic view that we see on the left-hand side. You can see that we're going down the access sheath here. We can then go down antegradely. You can see the mucosa is a little bit inflamed, which you might expect in this patient who's had nephrostomy tubes in for some time, but unfortunately there's no way through into that anastomosis. So having tried the left-hand side, you can see we've now got wire access down the right ureter, and we go through exactly the same process on the right. We pass an 11-13 26 centimeter access sheath down into the lower ureter. We're going to go antegradely down the right-hand side to try and find our stones. And in fact, on the right-hand side, we do manage to get down to some stone. We would then treat that stone just like you would retrogradely if you were doing a ureteroscopy, and fragment the stone, ideally dust it, but if needed, you can, with a basket, bring back fragments into your access sheath and remove them ureteroscopically back out through your access sheath. And then we'll pass down a track tip fiber. So there you can see on the II image that we've got access to the stones antegradely on the right-hand side. And we've got further fragmentation of stone here using our dusting settings. So for me, with our current 100-watt laser, this is going to be at a setting of maybe 30 hertz, 0.4 joules. I can't actually change the pulse width on this particular laser, but this very effectively fragments the stone into tiny fragments. And then you can see on this final image from this case that we've actually got access through to the conduit, with our ureteroscope on the right-hand side. So we know that there's a way through there. At the end of the case, we put nephrostomy tubes in on both the left and the right. And I think a key point in these patients is that you need to do early post-operative imaging. You've got access to the kidney already, that access is precious, and you don't want to lose what you've got if you might need it in the future. So unfortunately, the post-operative CT scan in this patient did show that there was a stone in the left ureter and also some residual stone in the right ureter. And given the fact that this patient has got complex anatomy and also had strictures at the anastomosis, the patient is scheduled for reconstructive surgery to reform a new ileal conduit. Understanding that you may fail to get up retrogradely is important. It's important not to spend too long struggling, subjecting the patient to a prolonged anaesthetic, and to say, do you know what, time's time, and we can now try and do things antegradely. So having the option to switch from retrograde to antegrade while the patient's on the table initially at the first time is always a good option. So be set up for that and be ready.